Hi, this is Dr. Akhtar and today's topic is orbital inflammation. Orbital inflammation may be infectious and may be non-infectious. The infectious inflammation, it may be preseptal or orbital cellulitis. The preseptal is anterior to the septum and orbital is posterior or behind the septum. The preseptal cellulitis is the infection of the subcutaneous tissues anterior to the orbital septum. It is more common, preseptal cellulitis is more common than orbital cellulitis, and it is less serious but can still be associated with severe complications such as abscess formation, meningitis, cavernous sinus thrombosis. The rapid progression to orbital cellulitis may occasionally occur. Organisms typically responsible are Staphylococcus aureus and Streptococcus pyogenes, with causes including skin trauma such as laceration or insect bites, and spread from focal, ocular or periocular infection such as from the acute hordeolum decrucistitis, conjunctivitis, sinusitis, and hematogenous spread from remote infections such as upper respiratory tract or middle ear. Preseptal cellulitis manifests with swollen and often firm tender red eyelid that may be very severe. However, in contrast to orbital cellulitis, there is no proptosis and there is no chemosis, and also the visual acuity, pupillary reaction, ocular motility, they are unimpaired. The patient is often pyrexial. Imaging is with MRI and CT. It is not indicated. Imaging is not indicated unless orbital cellulitis or lip abscess is suspected, or if there is a failure to respond to therapy. Treatment of preseptal cellulitis is with oral antibiotics such as coamoxiclav 250 to 500 mg by 125 mg 2 to 3 times daily, or depend on the severity. The dose depend on the severity, and severe infection may require intravenous antibiotics. The patient's tetanus status should be ascertained in cases following trauma. So in preseptal cellulitis, the visual acuity, pupillary responses, ocular motility, they are unimpaired, and proptosis is absent in preseptal cellulitis. And the treatment is antibiotics, cephalexin, amoxicillin, frequent warm compressed nasal decongestant spray. Otherwise hospital admission with IV antibiotics and tetanus status. In adults, the treatment depend upon the history, examination, antibiotics, the warm compress, and rate. Now the orbital cellulitis, the bacterial orbital cellulitis is a serious infection of the soft tissues behind the orbital septum. Bacterial orbital cellulitis can be silent and life-threatening. It can occur at any age but is more common in children. Streptococcus pneumonia, Staphylococcus aureus, Streptococcus pyogenes, and Haemophilus influenza are common causative organisms. From where the infection comes? The infection can come infection originating typically from paranasal sinuses, especially the ethmoid sinuses. So this is the most common cause, paranasal sinuses. Infection can also spread from preseptal cellulitis. It can also come from spread from decrucistitis, midfacial skin and dental infection, and can follow trauma, include any form of ocular surgery. Blood-borne spread from infection elsewhere in the body may occur. The clinical features, the symptoms consist of rapid onset of pain exacerbated by eye movement, so pain and eye movement, swelling of the eyes, malaise and frequently visual impairment, double vision. There is commonly a recent history of nasal or sinus or respiratory symptoms. So there is visual impairment, swelling of the eye movement, pain, malaise. Now what are the signs? The signs are pyrexia is often very marked. So there is high fever, which is not present in preseptal. The visual acuity may be reduced and color vision impaired, raising the possibility of optic nerve compression. The possibility of the presence of relative apparent pupillary defect in a previous normal eye makes this almost certain. Tenderness, firm erythematous and warm eyelids, and with periocular and conjunctival edema, conjunctival injection, subconjunctival hemorrhage. Signs are usually unilateral, although edema may spread to the contralateral eyelids. Proptosis is common. Proptosis is common and established infection, but it is often obscured by lid swelling. It may be non-axial dystropia, particularly if an abscess is present. There may be painful ophthalmoplegia, restricted eye movements, and choroidal folds and upon disc swelling may be present on fundus examination. So these are the clinical features: fever, leukocytosis, erythema, proptosis, chemosis, ptosis, restricted ocular movement, optic nerve compression, decreased visual acuity, impaired color vision, restricted visual fields, pupillary abnormality. A lot of features. These are the causes, and you can see what are the complications. The ocular complications include optic neuropathy. It can cause optic neuropathy, it can cause exposure keratopathy, it can cause raised intraocular pressure, it can lead to endophthalmitis and vein occlusion, central retinal artery or vein occlusion. It can cause cavernous sinus thrombosis, can cause subperiosteal abscess, most frequently located along the medial orbital wall. The intracranial complications are uncommon in 3 to 4%, but extremely serious and include meningitis and brain abscess. And the differential diagnosis of an acutely inflamed orbiter. The differential diagnosis ranges from infections to vascular lesions to neoplasia to endocrine diseases and non-neoplastic inflammation. So the bacterial differential diagnoses are bacterial orbital cellulitis, fungal orbital infection, dacrocystitis, infective dacroadenitis. The vascular lesions, the differential diagnoses are acute orbital hemorrhage, cavernous sinus thrombosis, carotid cavernous fistula. The neoplastic DDs are rapidly progressive retinoblastoma, lacrimal gland tumor, other neoplasms such as metastatic lesion with inflammation, lymphoma, Waldenstrom, macroglobulinemia, rhabdomyosarcoma, leukemia, lymphangioma, neuroblastoma in children. The endocrine DDs are thyroid eye disease of rapid onset. Non-neoplastic inflammations are also the DDs such as idiopathic orbital inflammatory disease, Tolosa-Hunt syndrome, orbital myositis, acute allergic conjunctivitis with lid swelling, herpes zoster ophthalmicus, herpes simplex skin rash, sarcoidosis, vasculitides such as granulomatosis with polyangiitis, polyarthritis nodosa, scleritis including posterior scleritis, and ruptured dermatitis cyst. These are all differential diagnoses of the acutely inflamed orbit. Now the investigations include assessment of tetanus immunization status in case of trauma, white cell count, blood cultures, culture of the nasal discharge, high resolution CT of the orbit, sinuses and brain is vital to confirm the diagnosis and exclude a subperiosteal or intracranial abscess. MRI is also sometimes performed. Lumbar function if meningeal or cerebral sinuses developed. Now the treatment. Hospital admission is mandatory. With urgent otolaryngological assessment and frequent ophthalmic review. Pediatric specialist advice should be sought in the management of child, and low threshold should be adopted for infectious disease specialist consultation. Delineation of the extent of erythema on the skin using a surgical marker may help in judging progress. Antibiotics are given intravenously with the specific drug depending on local sensitivities, supplemented by oral metronidazole to cover Anaerobes. Ceftazidime is a typical choice, which is supplemented by oral metronidazole to cover anaerobic. Intravenous antibiotics should be continued until the patient has been apyrexial for 4 days, followed by 1 to 3 weeks of oral treatment. Monitoring of optic nerve compression. Optic nerve function is performed at least every 4 hours initially by testing visual acuity. Visual acuity is checked every 4 hourly. Color vision is tested every 4 hourly. Light brightness appreciation. Pupillary reaction is checked every 4 hourly. Deterioration should prompt the consideration of surgical intervention. Surgery drainage of an eye orbital abscess should be considered at an early stage. Drainage of infected sinuses should be considered if there is a lack of response to antibiotics, if there is very severe sinus disease. Biopsy of inflammatory tissue may be performed for an atypical clinical picture. Severe optic nerve compression may warrant an emergency canthotomy or cantholysis. So, orbital cellulitis often occurs as a consequence of a sinus infection, so urgent radiological investigation of the sinuses is mandatory. So, what are the interventional criteria in abscess? If the patient is 9 years or older, frontal sinusitis, non-medial SPA location, larger SPA, suspicion of anaerobic infection, gas and abscesses on CT, recurrence of SPA after prior damage, acute optic nerve compromise, infection of dental origin. The last topic is Rhino-orbital mucormycosis. It is a rare, aggressive and often fatal infection caused by fungi of the family Mucorrhaceae and fungus rhizopus. Fungus Mucorrhacea typically affects patients with diabetic ketoacidosis. Diabetic ketoacidosis are the patients who are immunocompromised. Immunosuppression and extremely rare and immunocompetent. Infection is acquired by the inhalation of the spores, which give rise to an upper respiratory infection. Spread then occurs to the contiguous sinuses and subsequently to the orbit and then brain. Invasion of blood vessels by the hypa result in occlusive vasculitis with infarction of orbital tissues. Now the diagnosis, there is gradual onset of facial, the periorbital swelling, diplopia, there is visual loss. Signs are similar to bacterial orbital cellulitis but tend to be less acute, with slower progression. Infarction superimposed on septic necrosis is responsible for the classic black eschar that may develop on the palate. Here you can see on the palate there is black eschar. So always examine the palate, the turbinates, always examine the nasal septum, the skin and the eyelids. In case of any orbital cellulitis, always examine these structures. The complications include retinal vascular occlusion, multiple cranial nerve palsies. The patient may present with multiple cranial nerve palsies and cerebrovascular occlusion. And investigations is much the same as for bacterial orbital cellulitis. Now what is the treatment? Correction of the underlying metabolic defect should be constituted. Intravenous antifungal, daily packing, irrigation of the involved area with antifungal agent, wide excision of devitalized necrotic tissues. Exenteration may be required in unresponsive cases in order to reduce the risk of death. Adjunctive hyperbaric oxygen may be helpful. Thank you so much.